A very good morning to all speakers and participants. Thank you all for joining us today, this morning, for our regional conference on rare diseases in Malaysia and Asia Pacific. We really look forward to some insightful presentations and a productive discussion. Our focus for today will be on innovative financing mechanisms for rare diseases. To begin our conference this morning, IDEA's CEO Trisha Yeo will be launching the conference, followed by a pre-recorded welcoming speech by Yang Berbahagia Datuk Dr. Haji Rohaizat, the Deputy Director General of Ministry of Health Malaysia. I would like to start off by introducing Trisha. Trisha is our CEO at IDEAS. She is also a visiting research fellow at ICIA's Yusof Ishak Institute Singapore and a PhD candidate at the University of Nottingham, Malaysia. She is the author of States of Reform Governing Selangor and Penang and editor of several books. She writes and comments on Malaysian public policy issues, and her research focuses on federal-state relations in Malaysia. Over to you, Trisha.
Thank you very much, Vaishu. A very good morning to all of you. Yang Berbahagia Datuk Dr. Haji Rohaizat, Deputy Director General of the Ministry of Health Malaysia. Distinguished speakers, Dr. Asrul Akmal Shafi, Professor at USM, Angela Jackson, Lead Economist of Equity Economics, who joins us from Melbourne, Professor Nathorn Chayakunapruk from the University of Utah, Nadia Hanif Abdul Latif from the Phelan McDermott Syndrome Foundation here in KL, APAC Rare Diseases Network members, patient groups, Ministry of Health policymakers, and members of industry, friends and colleagues, and members of the media. If you're here, a very good morning to all of you. I'm very pleased to provide some opening remarks to our regional conference on rare diseases. Several of us, of course, would either have had friends or relatives who suffer from rare diseases, and even if we don't, we may have heard of them. So I'd like to begin my remarks by highlighting the spirit of those who have rare diseases as being strong and resilient, and often, especially in our region of the world, in the face of no treatment in sight. Let me give you some background to the project that IDEAS has been doing, and why is it that IDEAS, as an independent think tank, has been working on this subject. So the objective of our Championing from the Rare project, which started all the way back in 2018 to 2019, was to address the challenges that are encountered by patients with rare diseases in Malaysia. This ranges from treatment affordability to lack of awareness stemming from the absence of a national policy here. We aimed to run a research and advocacy project up to the end of last year, 2019, to number one, raise public awareness and support. Number two, develop and advocate for national policy by building coalitions with relevant stakeholders. We formed a working group with 5 experts in the field. The working group was the core entity within the project, and over the course of that year, we also built strong relationships with a range of stakeholders, patient groups, industry members, health professionals, government officials involved in the rare disease agenda. These multi-stakeholder relationships were further harnessed through consultations to understand the multiple perspectives involved in progressing the rare disease agenda. This project culminated with IDEA's participation in the government's newly formed Rare Disease Committee's first meeting, and we've had several meetings, both informally and formally, with the Ministry of Health. So this is a good step. The Malaysian government actually does have an intention of developing a national framework for rare diseases in Malaysia, and it's a promising effort to improve the well-being of individuals with rare diseases in Malaysia. But not just restricted to Malaysia, the APAC Rare Disease Network in the region will partner with Malaysia as the 2020 APAC host economy to organize an APAC Rare Disease Policy Workshop, and we look forward to that workshop. IDEAS, of course, is optimistic that this regional workshop will be a good effort in the right direction from APAC, and we hope it can contribute to the development of Malaysia's own rare diseases policy. So in this year, 2020, to develop the policy discussion on rare disease in Malaysia even further, IDEAS embarked on a research project to explore innovative funding mechanisms for rare diseases in Malaysia. So while the work on the framework was happening, it was felt that looking at the fiscal aspects was actually very important to develop this conversation. The fiscal paper considered a number of different options and highlights the main trade-offs and policy considerations with each. Following that paper, we have engaged with the Ministry of Health at various levels, and we understand from the MOH that the most favored option is the use of a trust fund model with an interest in regional collaboration. So the government here is keen to use this trust fund model, as has been adopted in other countries like Singapore, to fund rare diseases treatments. However, there are still questions that remain over the sustainability and governance of this trust fund. I'm very pleased and proud, therefore, today to say that IDEAS is releasing and launching a policy paper this very morning as we speak, titled The Next Steps for Rare Diseases in Malaysia, Improving Access to Treatment. And in this paper, we unpack this discussion and identify factors that need to be considered if a trust fund model is to be pursued. In the second portion of the paper, we draw lessons from 2 existing regional collaboration platforms aimed at improving access to high-cost treatment in Europe. And we encourage the Malaysian government to embark on regional collaboration efforts to improve access to treatments for patients with rare diseases. This regional conference that we are having today and tomorrow is a platform to develop this discussion on these 2 topics. And we would like to draw in insights from experts in the region, practitioners, those of you who have already been advocating for rare diseases. And with this, I'd like to conclude by saying that I hope that through our research and advocacy efforts, rare disease patients in Malaysia and the region will soon receive affordable and accessible treatment that they need through the robust, sustainable rare diseases policy achieved through regional collaboration platforms and other means. Thank you very much for joining us, and I'm very pleased to see all of you today. Please have a fruitful discussion during these 2 days, today and tomorrow. I am going to leave as a speaker, but I will be rejoining as a participant. So I'll be around, and I look forward to listening to all your very wonderful presentations. Thank you from IDEAS, and have a wonderful 2 days ahead.
Thank you, Trisha. Thank you for providing a valuable background on IDEA's work on rare disease since 2018. Our next speaker will not be able to join us live today due to other commitments. Therefore, we will be playing a pre-recorded video of his welcoming remarks. We're very honored to have the support of Ministry of Health for today's conference and for the rare disease research work done by IDEAS. Let me just give you a brief introduction of our next speaker. Dr. Haji Rohaizat is the Deputy Director General of Health in the Ministry of Health Malaysia. He retired on the 10th of June 2020 as the Deputy Director General of Health and was re-employed on a short-term contract at the same post since August 6th, 2020. A medical doctor by profession and also a public health specialist with subspecialty in health management, health economics, and financing. He obtained master's degree in health planning and Doctor of Philosophy in Public Health, majoring in health financing, health economics, and case mix. He has served the government for more than 33 years at various levels and has extensive experience in various MOH positions in the hospital and health service planning. He has also served 16 years at various positions in the medical program and 14 years in the planning division. Here are his welcoming remarks. Amir, could you please play his video?
Assalamualaikum and very good afternoon and salam sejahtera. First of all, allow me to express my gratitude to Madam Tricia Yeo, the Chief Executive Officer of Institute for Democracy and Economic Affairs, or IDEAS, and also the Chairperson of Organizing Committee, for inviting me to deliver a welcoming remark at this important virtual regional conference on rare diseases in Malaysia and Asia Pacific. A warm greeting to all speakers, Dr. Naresh Damrom Chai, APEC Life Science Innovation Forum, LSIF Co-Chair, Professor Nathan Chayang Kuprak from University of Utah, Dr. Arsul Akmal Shafi'i, Professor at the University of Saint Malaysia, Madam Angela Jackson, Lead Economist, Equity Economics, Dr. Eileen Lee, Director of Asia Pacific Alliance of Rare Disease Organization, APARDO, Mr. Kin Ping Tang, Rare Disease Hong Kong, Professor Dong Woon Han from Hanyang University, South Korea, Madam Nadia Hanim Abdul Latif, Phelan McDermott Syndrome Foundation, Mr. Lauren Todd, Director of Research Ideas, Madam Vai Navi, Senior Executive Ideas, also to other participants, APEC Rare Disease Network members, Dr. Kang Witik, Clinical Geneticist, MOH, Malaysia, Dr. Nguyen Loc Hoc, Clinical Geneticist, MOH, Malaysia, Professor Tong Myong Kong, Pediatric Geneticist, University Malaya Medical Center, Dr. Azina Ahmad Anwar, Department of Biomedical Science, Faculty of Medicine, University Malaysia, University Malaya Medical Center, and also representative from Medical Development Division of MOH, representative from Pharmaceutical Service Division of MOH, and representative from regional patient groups. I'm delighted that I'm able to be part of this significant event. On behalf of the Ministry of Health Malaysia, I would like to welcome our distinguished guests and speakers, both locally and overseas, and extend our gratitude for the participation. Your expertise, knowledge, and experience would certainly be a valuable input to our deliberation. The Ministry of Health Malaysia acknowledges the objective of this conference, among others, to address the rare genetic diseases issues by networking and heavily involve the rare diseases main stakeholders, especially the policymakers and the industry. This conference will be a platform to discuss on improving access to rare diseases treatment in Malaysia and also across the region. I was made to understand that ideas have contributed in facilitating a regional discussion on innovative financing mechanism region, and having participated actively in evidence-based, participated actively in value-based, educational and scientific activities. The Ministry of Health recognizes the need of the patient with rare diseases in Malaysia. Under the Malaysian National Medicine Policy, or MNMP, one of the focus areas to improve on is to enhance the accessibility of life-saving products and orphan medicine without compromising safety, without compromising quality and efficacy of the medicine. Pathways for accelerated access to orphan drug has been addressed, and it is being taken care of by the Pharmaceutical Service Divisions, to have a clear and simple approval pathway so that patients of rare diseases can get early access to the drug. Among treatments, they are available in health in Malaysia, in Ministry of Health now, currently include number one, life-saving medicine and treatment for number of acute intoxication type inherited metabolic diseases and orphan drugs for 200 inborn errors of metabolism patients. Number two, special low protein diet, special metabolic, for certain rare diseases patients. I repeat, special low protein diet and metabolic for rare disease patients. And currently we have 180 metabolic patients are receiving lifelong metabolic formulas from the Ministry of Health Malaysia. And number three, enzyme replacement therapy, a lifelong treatment for 46 46 lysosomal storage disorders patients. And with all the new technology and treatments modalities being already available worldwide, and we hope this conference is important because it will help identify the gap in healthcare, in particular for people living with rare diseases. Recently, MOH Malaysia has developed the National Framework for Rare Diseases for an integrated, comprehensive, and holistic rare disease management, which involve various stakeholders to establish policies, to establish programs, establish strategies, and intervention for rare diseases in Malaysia. And a definition of rare diseases in Malaysia has been set as a life-threatening and or chronically debilitating rare condition as listed in Malaysian rare disease list. And there are almost 500 diseases from multidisciplinary medical experts currently included in the list. The list will be revised periodically to be in line with the newly acquired knowledge, real-world evidence, and new treatment options to facilitate and ensure harmonization in the designation and also registration of orphan drugs. The Ministry of Health Malaysia, represented by the Medical Development Division, has been actively participating in the Rare Diseases Network since its establishment in 2017 by the APEC Life Sciences Innovation Forum. In 2018, Malaysian representative participated in the inaugural APEC Policy Dialogue and Rare Diseases in Beijing, China, and contributed to the development of APEC Action Plan on Rare Diseases, which was later endorsed by the APEC Health Ministers. Following that, last year, in 2019, MOH Malaysia has officially developed what we call National Rare Disease Committee, which involve representatives from multi-stakeholders collaboration and including patient partnership. Moving forward, in this coming December 2020, the APEC Rare Disease Network will partner with MOH Malaysia to convene the APEC virtual consultations on COVID-19 rare disease. I repeat, to convene the APEC virtual consultation on COVID-19 and rare diseases in Malaysia and APEC virtual policy dialogue on rare diseases in Malaysia and the Asia Pacific. Participants from Malaysia, as well as other APEC countries across Asia Pacific, will come together to explore ways in which key stakeholders can benefit from recommendations in the APEC Action Plan on Rare Diseases while considering their respective local contexts and policy environment. To this end, I'd like to invite ideas and teams to participate in this event and to share the consensus from this conference. The ultimate aim of all these services is to work toward reducing the effect of rare diseases and genetic disorders on the health of the community. We have achieved some success and should now strive for more successes through teamwork. With COVID-19 impacting the rakyat, the population, we have seen the spirit of kita jaga kita. All of us must follow SOPs. As we know, we haven't got vaccine available, and the only vaccine available are minimum 1 meter physical distancing, number one. Number two, we have to wear masks when we go to the certain places, crowded areas. And number three, we have to wash hand with soap or sanitizer. And very important, all of us must follow the new norm. Until the vaccine is available. And you can get this new norm in the MOH portal. And you can download this in MOH portal, and it is the way to go. Ministry of Health is anticipating with eagerness the input from all participants of this conference. May all of you achieve your objectives and enjoy the conference. Last and not least, Delima Selase, Duku Mengkudu, terima kasih, thank you, love all of you.
Thank you for that, Dato Rohaizat. We are very honored to have your welcoming remarks, and thank you for giving us a brief background of what rare disease framework and committee in Ministry of Health has sort of achieved in the last few years and the direction moving forward, and also for a very important reminder on maintaining SOPs and staying safe. I will now hand over to our moderator for today, Nadia Hanim Abdul Latif, who will introduce our presenters for today and moderate the panel discussion. Dr. Nadia is a strategic advocacy and corporate affairs professional. Dr. Nadia is also a strategic and advocacy, with over 20 years of experience ranging from corporate to NGO and humanitarian work. Nadia has had the opportunity to engage stakeholders from grassroots advocacy to participating in discussions on legislation and national action plans, both in Malaysia and abroad. At present, she is a sustainability and corporate affairs consultant, the co-founder of social enterprise Opus International, a program host with Bernama News Channel, the vice president of the Malaysian Rare Disorder Society, the regional representative for Southeast Asia, India, and South Korea for the Phelan-McDermott Syndrome Foundation. Before I hand over to Nadia, I would just like to make a quick note that Professor Naton will be joining us a little later this morning due to prior personal commitments. I would also like to remind everyone that you can ask your questions throughout the conference using the Q&A feature. So please do send over any questions you may have. And that's it for me. Over to you, Nadia.
Thank you. You've made my day. I became a doctor this morning without actually doing a PhD.
My apologies.
Thank you so much for that. Oh no, it's okay. I'm fine with that. I'm not sure if the doctor's all right with that. Good morning. Salam sejahtera. A very warm welcome, everyone. Thank you for joining us this morning, despite the fact that we are on an extended MCO in Malaysia. Thank you for joining us bright and chirpy in the morning. First up, we have a policy presentation paper by Ideas, and it will be presented by the Director of Research and Development of Ideas, a dear friend, Mr. Lawrence Todd. Now, Lawrence is a public policy professional with a wide range of economic policy, business regulation, and international trade experience. Prior to joining Ideas, Lawrence also served a number of roles with the UK government, including in Her Majesty's Treasury and the Ministry of Defence. Now, when he's not doing all the policy work that he is, he's also actively engaging non-limitation action groups, as well as appearing as our celebrity on Bernama when he gives his thoughts on budgeting and on policies in Malaysia. Now, a quick shout out to everyone here. We do have a panel discussion that will be followed by question and answer session. So please feel free to ask whatever questions you may have on the chat box within your Zoom, or you could also use the question and answer function. So without further ado, Lawrence, take it away.
Thank you very much, Nadia, for that very generous introduction, and good morning and welcome to everybody. Very pleased to be able to present our work today. So I'll try and keep it relatively brief because we've got some excellent other speakers to hear from, but I'm just going to share my screen with you all. So, as alluded to by Trisha in her opening remarks, today we're publishing a paper that's sort of diving into some specific options to improve access. And the one I'm going to speak to you about for the next 10 or 15 minutes or so is the option for a trust fund. So this is quite a focused discussion of this particular option. And then I hope that I've seen already Dr. Azrul and Angela's slides, and I know they'll be able to kind of broaden out the discussion to look at other financing tools. But what I'm going to cover just now is the specific option of a trust fund, because the government has indicated that that's a direction they're considering to pursue. But I'll just start off with some context on the broader financing landscape in Malaysia. So healthcare financing in Malaysia and rare diseases. So of course, the main driver of healthcare expenditure in Malaysia is the public healthcare system. The Ministry of Health directly accounts for about 40% of healthcare expenditure in Malaysia through the various public hospitals and other clinics. Now, with respect to how treatments are made available on the public healthcare system, that is based on health technology assessment, but we don't currently in Malaysia use an explicit cost threshold. So I think that's an important piece of context in discussing access to rare disease treatment, which is that the toolkit that the Malaysian public health system uses does not include an explicit threshold, although there is some implicit guidance on the sort of value for money considerations. With respect to rare diseases, orphan drugs, there is no currently a dedicated process for orphan drugs, but as Dr. Rohaizat indicated, that is something that's being developed as part of the rare diseases framework. And there is an annual ring-fenced allocation, which is used to support treatment for the specific treatments that Dr. Rohaizat mentioned. Second pillar of healthcare financing is private insurance. So we can see this makes up a significantly smaller element of overall healthcare expenditure in Malaysia. Private insurance only accounts for about 7% of healthcare expenditure. There is very minimal coverage of rare diseases in available private healthcare policies in Malaysia due to genetic nature, pre-existing nature, and so on. There's also a problem in terms of the lack of data, which limits the actuarial assessment of product viability. So the overall private insurance market, it remains relatively underdeveloped in Malaysia, and as a result, rare diseases is not something that is typically covered. Finally, we have social insurance. So this is something that's actually growing in Malaysia. We have two vehicles, EPF and Percaso, although rather EPF is less insurance and more of a savings vehicle. But combined, they account for about 1% of healthcare expenditure, although that is on the rise. Now, neither of these schemes have real and significant application to rare diseases. Percaso is linked to employer contributions and EPF is linked to savings. So across these three pillars, we can see that in Malaysia, in the context of rare diseases, the current access is really provided by the public healthcare system. Now, in terms of options to improve access, we at Ideas have been looking at this for the last year or so through a series of different publications, including by Dr. Azrul, Professor Tong, and Dr. Azlina, as have been introduced. And this culminated in a set of options that we presented to the government of different policy ideas that are available from international examples or from developing on existing tools within the Malaysian context. I'm sure we'll have some opportunity to discuss the merits of these different options in the panel. I won't go through the detail, but they're summarized in that table on the left, and they're all available in our white paper, which we published last year. So we talked about how to expand public financing, looking at a trust fund, private insurance, and social insurance, and the options to try to develop these models to finance wider and deeper treatment to rare diseases. Now, when we presented this, the government expressed an interest in developing the trust fund model to improve access to rare disease treatment, which has led us to the current exercise, which is to drill a bit deeper into this particular model. So the research questions we tried to answer in this current paper is, how can a trust fund improve access to rare disease treatment on a sustainable basis? Second, how does a sustainable trust fund need to be governed to maximize equity? Third, and this is important, is do existing models, and particularly by this I'm referring to the Rare Disease Alliance Foundation Malaysia, meet the necessary requirements, i.e. There's been some suggestion that RDAFM could take up this role of providing the trust fund. So the question is RDAFM in its current form able to do that? And then what policies are needed to ensure a trust fund in Malaysia is sustainable and well governed? So these are the questions that we seek to answer in the current paper, and I'm going to run through our conclusions today. I will be quite brief, but please, if you're interested, very happy to drill into some of these issues in the panel, and of course, encourage you to download the paper and read through the discussion in more detail. So in order to inform the thinking on this, we look at some examples of international collaboration, of international trust funds. Just trying to click through it, yeah. So we look at the Rare Disease Fund in Singapore, a public-private fund, which is with an endowment, which uses interest to support access to treatment. It's about 90 million Sing dollars and is designed specifically to access a specific set of approved orphan drugs for patients who cannot afford access. We then have the Bhutan Health Trust Fund, which is a government administered fund, but is supported by private donations and various investment mechanisms. It's about $4 billion and is actually used to finance procurement of essential drugs and vaccines in Bhutan across the healthcare system. So it's not rare disease specific. Next, we look at the Cancer Drug Fund, which is not a trust fund, but in its nature is a ring-fenced fund within a public healthcare system. It has some important parallels and therefore potential lessons for the Malaysian context. So this is a ring-fence allocation for cancer drugs in England. It's about £340 million. And it's specifically designed to enable access to new treatments via managed access arrangements while further evidence is collected to address clinical uncertainty. And as I say, because it forms part of a public healthcare system, it has some parallels to the way we run our public healthcare system here in Malaysia. And then finally, just to include for purposes of comparison, of course, the Rare Disease Alliance Foundation Malaysia is not a fund in that sense, but because it has been mentioned in this discussion about having a trust fund, I wanted to include it here for the purposes of comparison. So the RDAFM is a trust, a yayasan established to provide a national alliance and platform for patient groups in Malaysia. It does not, it's not endowed with any specific fund, although it does engage in some fundraising. And its scope is to provide a unified voice to speak for patients and families affected by rare diseases in Malaysia. So we can already see by its design, it's not intended as a fund to facilitate access to treatment. So the first aspect of a functional rare disease trust fund is sustainability. And by this, we really mean being able to sustainably finance access to treatment. So really this comes down to sources of funding, and we identify across these different models a spectrum of funding options. On the one hand, we have purely public sources, so annual budget allocations, maybe a public endowment, the issuing of government bonds, and so on. On the other end of the spectrum, we have fully private funding, which essentially is donations, whether those be personal or corporate. Then there are some hybrid financing options, so tax incentives, government matching, and investment income. So for tax incentives and government matching, this is about leveraging public finances in order to maximize the private financial contributions. So that's why we consider it a hybrid option. And investment income is simply generating a return on the principal fund that could have come from either a public or private source or a combination. So if we return to our international examples, let's start with the RDF in Singapore. Now, the RDF uses these financing mechanisms: donations, tax incentives, government matching, investment income, and is all based off an original endowment. So quite a broad range of financing mechanisms used to ensure the sustainability of that fund. Next, we have the Bhutan Health Trust Fund, which uses these options. There are private sector donations, but mainly there's a significant public endowment and through the issuance of bonds, and then subsequently generating investment income that's used to finance the procurement of drugs. Third, we have the Cancer Drugs Fund. Now, this is relatively few tools, but it's really just an annual budget allocation from the NHS used to then finance access to the to those cancer drugs that have not yet had sufficient demonstrated clinical effectiveness to be commissioned on the whole, across the whole piece. And so then, for the sake of comparison, we have RDAFM, which I'm really including here as sort of also a proxy for the wider patient group network, which is really just donations. And I think I even put it in dotted line because, as we'll come on to, RDAFM is actually not empowered to raise money specifically for treatment. So really it's only a fundraising platform to offer support. So then in this context and in this comparison to other funds, the immediate next question is, are donations enough? Are donations going to be enough to ensure sustainable access? So the current situation is that fundraising in Malaysia is patient group led, with some ad hoc support from government. The main source of funds is personal donations, so friends and family, and fundraising through platforms like social platforms that leverage donations from individuals. Corporate donations have been quite limited by two things: a lack of awareness of rare diseases as an issue, and the cost-benefit justifications that apply to CSR programs. So speaking with corporate CSR programs, there's concern around the amount of money that has to be spent in order to support, say, one patient. So actually quite similar concerns that get raised by the corporate sector as get raised by the public healthcare system. And then finally, that as a result of these factors, the funding is used mainly for income support. So the money that is raised through patient groups is not generally used to finance treatment. And if it is usually only possible to do that on a very partial, i.e. time limited basis. So for example, financing the first 3 months of treatment before sustainable treatment then has to be handed over to the government. So in that context, we conclude it's quite clear that to be sustainable, the trust fund will need to be supported by and leverage public funding. Now, there are a set of different options to do that. Absorbing the existing ring-fence budget allocation as a start, potentially establishing an endowment, tax incentives, government matching, and finally, not direct financial support, but simply confidence building among corporate donors. So using the government platform to overcome some of those barriers that the corporate sector have to donating to rare diseases as a cause through using the convening power of the government. So these are our conclusions in terms of the requirements to make a trust fund sustainable from a financial perspective. Secondly, we look at the issue of governance, and I think that crucially the governance discussion flows directly from the previous conclusion that essentially some public financial investment is going to be necessary to ensure that the trust fund is sustainable. Now, looking across the different examples that I highlighted earlier, we identified the following crucial governance factors that have to be determined in order for the trust fund to be well governed. The first is the scope of the fund. It's actually not entirely clear at this point whether the fund is intended only to meet the cost of orphan drugs or for other treatments for rare diseases and potentially even non-treatment costs. So some of the money that's raised through the patient group networks is currently being used, for example, to pay for testing, particularly where tests have to be sent overseas, for example. So whether or not this fund is solely an orphan drugs fund, as is the case with, say, the RDF in Singapore, or is intended as a sort of broader platform to support the needs of rare disease patients. Second is the eligibility of treatments. So given particularly that we judge that some public financial contribution will be necessary, it's very important that those treatments that are available, of course, have to tie in with the wider public healthcare system. So i.e. will treatment be limited to those drugs listed on the formulary? And then we can't really escape the kind of public finance questions that emerge. So for example, will there be a cost threshold such as in the UK case? Or reference pricing, which is what the Singapore fund uses, and so on. And then the other part of the eligibility question is means testing. So in the Singapore case, that it is intended as a means tested fund, whereas obviously in Malaysia, our public healthcare system works on the basis of universal access. So I think it's clear that this fund would need to be an extension of the public healthcare system and therefore could not operating on a means tested basis. But this is something that just needs to be settled. Third is the technical expertise to support the decision-making of the fund. So who will provide technical advice to the fund? Would this be existing Ministry of Health structures, such as MyHTA or the pharmacy division, as Dr. Rohaiza alluded to, or would a new structure need to be established? Now, this is the case in the Singapore case with the Rare Diseases Expert Group, which advises the Rare Diseases Fund. So there are some mechanisms existing within the MOH. There was previously a Rare Diseases Committee that could be remobilized to support the decision-making of the fund, but it's certainly very clear that technical expertise is required to inform decision-making on the allocation of funds. Finally is actually the decision-making itself. So here the question really is, who is empowered to make decisions on who receives funding, particularly in the context of a degree of public investment in making the fund sustainable. So who is the decision-making authority? Is it solely public officials, i.e. essentially becomes an extension of the Ministry of Health, or would we seek some broader involvement of community? So in Singapore, various community leaders are part of the decision-making on the trust fund. And I think there's two factors that are really important to consider here. Firstly is the need to ensure public accountability of any use of public money. And B is to limit conflict of interest. And I think we can recognize that that would affect the role for patient groups directly in making decisions, and therefore the need for patient groups more likely to play an advisory role rather than decision-making role. So finally, and this is not intended to be any kind of criticism, I think the RDAFM would agree with this. I think when we consider these four factors of what constitutes a well-governed trust fund based on the international precedent, I think we can see that RDAFM is not currently equipped to provide this platform. So for the scope of the fund, I put that as a question mark, because actually under RDAFM's constitution, it cannot raise money for treatment. So RDAFM is empowered to raise money for certain non-treatment costs, but clearly if that's the direction that we want the trust fund to take, it's actually not going to be achieving the goal of improving access to orphan drugs. In the other three categories, I think the current format of RDFM is not equipped to either make decisions on the eligibility of treatment or to have the sufficient technical expertise to advise on decision making or represent the full range of constituents that would need to be involved in decision making. And in particular, that means having government and public representation in that decision making. So I know I've run a bit over time, so I'll wrap up quickly. So the conclusions that we draw in this section of the paper on how to make sure a trust fund works is that a trust fund can provide a route to improving access, but firstly, patient group-led fundraising is not going to be sufficient to ensure sustainable access to treatments. So if the intention is solely to channel patient group fundraising into a trust fund, that is not going to be sufficient to improve access. As a result, the public sector will need to play a role financially, but with a range of different options that can be more focused on facilitating and leveraging, such as convening private donors through to tax incentives, government matching, all the way through to directly supporting financially, either through an initial endowment or through an annual budgetary allocation. So there is a range of options, but we need to be clearly in that space if we are talking about genuinely sustainable access. Thirdly is that the existing structures, i.e. the Rare Disease Alliance Foundation Malaysia, are not really equipped to govern such a fund, and therefore new structures are needed or reform to the existing structures. So I think that the direction towards a trust fund can be very positive, but we just need to be very clear, I think, on these 3 points to ensure that a trust fund does actually improve access to treatment in Malaysia. So I'll conclude there. It was a quick rattle through, so very happy to get into further discussion in the panel, but for now I'll leave it there. My last word will just be to acknowledge the really helpful inputs we received from various stakeholders, including patient groups and the academics that we've worked with for a couple of years now, including Dr. Azrul, Professor Tong, and others. So very grateful for all that input, and hope this is a constructive contribution to the journey of trying to improve access to rare disease treatment in Malaysia. Thank you very much. Nadia.
Thank you, Lawrence. So as we can see, the journey is not an easy one. It is quite complicated with a number of different things to consider. Thank you also for acknowledging that the rare disease community and ecosystem in Malaysia is varied with multi-stakeholders involved in it. So I wanted to take the opportunity to acknowledge all of our friends and stakeholders within the ecosystem, of course, starting with the government. We've also got our corporate partners who've assisted us not only in our CSR fundraising, but as well as those who are from the pharma, members of the media who've helped us to really channel out some of the key issues that we wanted to bring out not only to the government, but as well as the last recommendation that you said, to increase awareness on the rare disease issues in Malaysia. Of course, our dear medical practitioners, our geneticists, our patient counselors, our doctors, strong patient advocate groups, caregivers, youths, and of course, individuals with rare disorders themselves. So with that, I'd like to open up to the next section of the forum today, and it would be a panel session on innovative financing for rare disease therapies. We have 3 separate presenters that would go back to back, and then we'll open it up for a panel discussion for everyone. So as I repeated again, there will be opportunities for you to ask your questions. Please do so. I see Bruce's question in the Q&A box. Thank you so much for that. Please keep your questions coming. So the first presenter we have is Dr. Asrul Akmal Shafi'i. Of course, another legend in the Malaysian rare disorders space. His research interest really is in pharmacoeconomics and health service research, and he has published more than 200 peer-reviewed journal articles, books, monographs with an H index of 35. He is the editorial board member of the Pharmacoeconomics and Value in Health Asian Region Journal. He's currently the board member of HT Asia Link Network and a core member of ISPO Code of Ethics Task Force. He has been appointed expert member for the UK National Institute for Health Research Committee, Malaysia Health Technology Assessment, HTA Agency, Malaysia Pharmacoeconomic Guidelines Development Committee, Malaysia National Medicine Policy Steering Committee, Ministry of Health Quality Use of Medicine Committee, Malaysia Institute of Health Service Research, Malaysia Pharmacy Advisory Board, and Malaysia Pharmacoeconomic Technical Committee. So as you can tell, a highly illustrious individual. At present, Dr. Asrul is the Director for Institutional Planning and Strategic Center in USM, University Science Malaysia. And he will be presenting today on health economics for rare diseases in Malaysia. Dipersilakan.
Assalamualaikum and good morning, everyone. Thank you, Nadia, for the kind introductions. I don't think I'm qualified to be a legend. I'm just one of the researcher trying to help out the rare disease patients in Malaysia. First of all, I would like to thank also Ideas for hosting and also for keep pushing the agenda of rare disease. I think, let me just bring my presentation first here. Okay, share screen. Okay, so these discussions today that I'm bringing to this forum is based largely on the study of my PhD student, Azwana Supian. And I would like to start the discussion with 2 quotes from the patients that we interviewed in the study. From birth, he was okay. However, when he was 1 year, have a fever on and off, and then it took almost 10 years to know the actual illness for the patients. Another quote is from a different patient who actually commented that he needs to take a few years for his sons to wait to get the treatment for his disease. And these 2 actually illustrate the problem of access to rare disease patients for their medicines. And which is why the focus of my discussions today would be on access to medicine for these rare disease patients. In order to give a better pictures to those who are not familiar with how medicine access in Malaysia, so I would like to just bring you to just a quick overview of the access to medicines from left to right, where we have the drug for these, the medicine for the rare disease be developed by the industries, and then followed by it's being sent to these market in the countries. So in Malaysia, we have these national pharmaceutical regulatory agencies, which would give authorizations for the drug to be marketed in Malaysia. So once it's been approved, so it will receive a registration number to show that it is a licensed medicines. So once it's been licensed, then it can be consumed by the patients in the market. And at that stage as well, the Ministry of Health and other government agency would decide whether we should use the public fund to pay for the medicine. And this is done, this evaluation is being done by the Pharmaceutical Service Program in the Ministry of Health, Malaysia. So once it's been decided that the medicine is approved for this for the use of the patients in the government hospital, so the medicine will be listed in the formulary of UBAT, formulary UBAT, or we call it the Blue Book for the Ministry of Health in Malaysia. And finally, then it can be prescribed and also being used by the patients in the government hospitals. So we also see at the end of the other spectrum is that there are also another pool of patients which being left undiagnosed and untreated, which is also another problem which prevalence in patients, in rare disease patients. So I would like to bring in 3 issues here in our discussions regarding the access to medicines in Malaysia. One is the problems that we have with the rare disease medicines to actually meet the public agency's requirement, either for registrations or for the financial coverage. So rare disease medicine or orphan drug, they are naturally, they have limited evidence to support their applications. So what usually we have with the studies that try to support these medicines is that they have a no control arm, they have small study populations, well, they are rare disease. They have no validated outcomes, so the disease is heterogeneous, but the sample size is very small. So making statistical analysis very difficult or inconclusive. And there is also usually no long-term data as well to support the use of medicine in the long run. So with that, then the public agencies, either for the registrations or for the coverage, have issues of trying to understand whether the results that they be obtained from elsewhere can be transferred to the Malaysian scenario, whether it can be generalized, and how can we estimate properly the benefit of the treatment, especially when you don't have, when you cannot run a proper statistical analysis on the studies. So another problem that we have with the documentations of orphan drug or medicines for this rare disease is that there is insufficient background data that we have in the countries. We do not know how many people have the disease. We do not know the prevalence. We do not know the incidence. We do not know much how it's being treated now, and what is the unmet needs that we still unable to do it in our current system. So because of that, then the public agencies have a problem of trying to understand what would be this new treatment be adding to the overall pathway of the treatment now, and who will be this new treatment targeting to, how much it will actually cost, and what will be the place of this new treatment in the overall pathway of treating the patients. And finally, this is the uncertainty about the cause, because we do not know much about the epidemiology of the disease. So we cannot understand what would be the burden then with this new treatment compared to the existing now that we have for the patients. And also because these rare disease patients, we see that there's a growing expenditure on the orphan drug, and because of the high cost of the medicines, and because of that as well, we see that all of these will result in the high incremental cost effectiveness ratio of orphan drug. So this incremental cost effectiveness ratio, ICER, is the value how much we need to pay to get one additional benefit. So this is usually the parameters that is being used in order to know whether a drug is cost effective or not. So because the drug is expensive, the benefit is uncertain, so most likely we would see a very high incremental cost effectiveness ratio, which is above the threshold of cost effectiveness that has been described by Lawrence earlier. So all of these problems with this uncertainty that we have with the cost would result in the problem by the public agencies to actually accurately quantify the healthcare costs, and also what is the saving that could be expected over the lifetime if we have this new treatment in the pathway. So because of that, then we see some of these drugs. Okay, so we have to remember that in Malaysia, we do not have a specific pathway for orphan drugs. So they are being evaluated in the same way as any other drug being evaluated. So because of that, then many of the evidence that being required earlier on might not be able to be met by the drug for the rare disease. So some of these medicines that we see in Malaysia for the rare disease patients, some of them are able to be registered. So they pass the first hurdle, which is actually to be registered in the market. And they also able to pass that they are qualified to receive funding from the government, which is what meant by a tick in this formulary here. But we also see some of the medicines which pass the hurdle of being registered, that we allow them to be marketed in the specific countries, but they are unable to pass the hurdle of being covered by the government. Okay, so some of these medicine here, for example, the allosulfase and galsulfase, okay, so they are being registered but not in the formulary. But there are also some other drug as well, which doesn't pass both hurdle, okay, so remain out of reach to the Malaysian populations. So that is on the first issues that we have of the access of the medicines. The second part is actually belong to this area here, where we have a large pool of patients who are still undiagnosed and also untreated, mostly because we have lack of expertise and facilities in Malaysia. So this map here shows the distributions of experts in the rare disease, particularly the genetics, in the whole countries. So we have only one private hospitals here who have their expertise. We do have the PH here. It doesn't mean anything political here. PH here means public hospitals. So there are only 4 hospitals that have this expertise, and the rest of the states actually only have visiting specialists coming through them, coming to visit the patients on a specific intervals. So the whole countries, we only have 13 specialists and 12 MOs. Some of these samples that we have from the patients, you have to send out abroad to Australia's facilities to be properly diagnosed, and the waiting time can take a long time before even it reaches to that stage. Most of the time, patients would have to meet, because there's lack of expertise, so whenever they met a doctor to try to diagnose, to get the proper explanation for their disease, because there's lack of expertise, it remains undiagnosed until they be able to see the proper persons or proper experts. The third issues we have with the access is at the point of consumption, mainly because it is expensive. So some of this disease here, some of the treatment for the disease here, for example, here as you see Pompe disease, the drug here is myozyme. So it is being registered and it is also listed in the formulary. The cost for 1 unit, for 1 vial of the treatment is 2,534 ringgit. And as you can see here, for a patient to receive a 1-year treatment with myozyme, it costs 500,000 ringgit. So mind you that the poverty line for Malaysia is 2,200 ringgit, if I'm not mistaken. Okay. So that means that the cost for the patient a year is actually about 20 times of the poverty lines of the for the Malaysia. And this is actually beyond catastrophic already. So if you see at the end of the spectrum that I arranged here, okay, for the medicines here, some of the medicine can reach 1 million per patient per year, which is actually very, very expensive. And it's not even covered in the formulary or covered by the government. So it has to be paid by the patient themselves. So one simple analysis that we did with the idursulfase ERT, we tried to see how much does it cost per year if we include everything. So the treatment itself, the drug itself, it costs about 700,000. But the rest, the cost of seeing the doctors, the cost of monitoring it, follow-up monitoring, altogether, a patient with that receive idursulfase can cost about 710,000 every year. So which is actually small wonder that what we see here in this slide here, that many patients, quite a significant number, more than a third of the patients still do not have access to a proper treatment for their conditions because of these 3 issues that I have discussed earlier. Number 1, the difficulty in the for the drug to meet the strict documentations requirement by the public agencies. Number 2, the lack of expertise that we have in Malaysia to properly diagnose and also treat the patients. And also number 3, the high cost of the treatment itself, which make it beyond the reach of most Malaysians, especially those who have to rely on their own fund to receive the treatment. So we have seen in some of the patients who are actually receiving the drug through private donations, and also compassionate program from pharmaceutical companies. But we all know that, as what Lawrence have described earlier, these 2 options, source of funding, is hardly sustainable. So many of the patients actually have a very anxious. Will we be receiving the drug again next year? So this is actually a very valid questions. And I hope that this forum will be able to actually light some ideas on how to make sure that we have a sustainable financing source for the rare disease patients. With that, I would like to conclude my discussions today. I would like to thank my PhD students, Azwana Supians, and clinicians, allied professionals who have tirelessly been there treating the patients, the support groups, the parents, and of course, the patient themselves, who are being very strong to this end, to this cause. So thank you very much. Assalamualaikum.
Thank you very much, Dr. Asrul, for your presentation. Just to share with members of this forum, the national poverty line for Malaysia was actually revised in July 2020 from 908 to approximately 2,208 in July 2020. Now, this means that approximately 400 1,000 households in Malaysia are living below the poverty line. And while this number is being revised by Department of Statistics Malaysia, what we also know is because of the prolonged MCO and the impact to the economy due to the pandemic in COVID-19, we are also seeing an emergence of the new poor, what we call the new poor. We once upon a time had this term of the new rich. We now have the term the new poor. Now that of course will have all sorts of impacts and implications, especially to minority groups like the rare disorders community in Malaysia. But before we dive into that in our panel session, I would like to invite the next speaker who will be talking about funding rare disease therapies in Australia. We have the lovely Angela Jackson, who is the lead economist of equity economics. Angela started her career as an economist at Australia's Department of Prime Minister and Cabinet and has worked across tax, fiscal, and social policy. Now, the then Finance Minister, Deputy Chief of Staff, Angela worked on the government's response to the GFC and major reforms across health, education, and disability sectors. Now, she has authored major reports on rare diseases in Australia, including funding rare disease therapies in Australia in 2014, living with Duchenne and Becker in Australia, supporting families waiting for a cure this year in 2020. Now, Angela is also a non-executive board member and finance committee chair of the Royal Melbourne Hospital, a member of the Victorian National Heart Foundation Advisory Board, and the deputy chair of the Women in Economics Network. Angela holds a master's in international health policy with a distinction from the London School of Economics and Political Science, a Bachelor of Commerce from the University of Melbourne, and another Bachelor of Economics from the University of Tasmania. She submitted her PhD thesis in the economics of disability in September 2020. So Angela, the floor is yours.
Thank you very much. Thank you, everyone. Before I start today, I would just like to acknowledge the traditional owners from where I'm calling to today, which is in Melbourne, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past, present, and emerging. Look, it has been fascinating just to listen to the first two presentations today to recognise how similar the issues that we face in Australia and Malaysia. And I think pretty much health systems around the world are grappling with these issues at the moment. And the reason, of course, is that while rare diseases have been around forever, we both have much more technology now to recognise them and through genetic testing to identify what the diseases are, but also to treat them. And so for health systems that have been used to dealing with diseases that affect a lot of people, for the first time we actually have the resources and the ability to now treat those diseases which do affect a large proportion of our populations, but a relatively smaller number for each individual disease. And I think what we're seeing across the world is there are new ways of dealing with that, and that the health systems are having to adapt so that we can provide these treatments for the first time to people where previously there were none. Now in Australia, I guess what I'm going to talk to you today really is sort of a high level presentation about what has happened and what reforms are occurring. Now, we have medicines regulation, which for rare diseases is pretty much done through two streams. So similar again to Malaysia, where to just get access to the market, you have to be deemed to be safe. And that goes through the Therapeutics Goods Administration. And there is also for gene technology, which is increasingly important, of course, for rare diseases, we have a separate process through the Office of the Gene Technology Regulator. There's been quite a lot of issues with that regulator that the rare diseases community has raised. And I think one of the reasons for that is while it's obviously dealing with now medical treatments, a lot of its processes weren't necessarily set up for that. It's to do with all gene technology, so across a broad spectrum. And so it hasn't had perhaps that medical focus that people in the rare diseases community would have liked. Then we move on to, of course, and Australia has a very long history of this around health technology assessment. And for medicines, that involves going through the Pharmaceutical Benefit Advisory Committee as the first step, where there is an evaluation. Again, we don't have a set ISA in Australia, but we all sort of understand that there is a set ISA of around for somewhere between $30,000 to $50,000 a year per quality adjusted life year tends to be where things get approved. Now, obviously for rare diseases and for orphan drugs, they rarely meet that threshold because of their cost, but they still have to go through the process. And this is one of the bugbears still in the process, whereby you know you're never going to meet that threshold. You still have to go through quite a long and arduous process. When you fail at that, you can then go to the life-saving drug program, which is a separate program. It still adheres, I guess, to the health technology assessment, but it is really there for drugs that are both for diseases, for the treatment of diseases that are both life-threatening and where there is no alternative. It's a much more stringent process. There have been reforms to that, which I'll talk about through the presentation. Now then, separate to that, and again, I think quite relevant, is around procedures, which includes gene therapies in Australia, which goes to the Medical Services Advisory Committee, and that oversees our universal healthcare system. So if new procedures want to come on to and be used in Australia, they have to get funded, they have to also meet this sort of cost effectiveness threshold. Now, again, I think it's important, and we've talked about this today, is that while each individual rare disease is rare, overall they're not. So in Australia, it's estimated 1 in 8 Australians have a rare disease. This makes it more common than diabetes to have a rare disease, which is why it is important that our health system can treat and help people with rare diseases as well as other people with other diseases. We know that many have no cure or treatment, but that this is also changing. So with new technologies becoming available, it's an incredibly exciting time for the rare diseases community around the world. But it is challenging, obviously, for government because it comes at a significantly higher cost. So some of the gene technology treatments are around $2 million per patient. These are exceptionally high costs for health systems to sort of anticipate or plan for, let alone work out who they fund and who they don't. So looking more broadly, I guess, and my presentation sort of separates the orphan drugs from the gene therapies and how Australia is dealing with both. So again, this is approved like the normal process through the Therapeutic Goods Administration. Some can be funded through the Pharmaceutical Benefits Scheme. It is open, but generally speaking, they don't meet the threshold. Now, our PBS spends around $12.6 billion a year providing free drugs to Australians and subsidised medicines. That represents around just under 10% of the overall spending on health across the board. So it's a significant amount of money that goes towards medicines. The Life-Saving Drugs Program, as I said, is a separate part of that, and it recognises, I guess, this idea of the rule of rescue, that for people who there is no alternative, the system should step in and provide access. But it is a relatively small scheme. It only provides support to around 400 people across Australia, and it provides access to around 16 medicines at the moment, at a cost of around 130 million a year. So compared to the overall size, I guess, of the medicines budget, it is a very small amount each year. Now, there was a lot of complaints around the Life-Saving Drug Program about its, that it was opaque, that it was difficult to navigate, that it wasn't providing the access that it was meant to for people with rare diseases. And so after a lot of sort of talking with government, it was reformed quite significantly in 2018. And that transparency has been improved. They've instituted an expert committee to oversee it and to advise. And I think overall there is, I guess, greater satisfaction with that process now, although there is still, I think, within the Australian context, and it's something perhaps we'll talk about in the panel, a real resistance to move away from those traditional health technology assessment type approaches in Australia, whether it's because of our long history with it, and so people are very tied to it. There is, people don't want to necessarily move away from that health technology assessment approach to a broader look at what value might be, to things like, for example, multi-criteria decision analysis. There has been, I would say, a very heavy resilience from within government to change the approach. Now, in terms of gene technology, this is something that is, obviously offering a lot of hope for people with rare diseases in Australia, but it is causing also anxiety in terms of the delays in access. So we know that there's this growing pipeline of new treatments that's coming along. It's anticipated, I think, there'll be up to 20 a year by the middle of this decade that will be coming onto the market. they offer obviously transformational change for people with rare diseases, where they may be able to actually provide a cure. And for the report that I did earlier this year for SOS Duchenne, which is a degenerative disease that affects mainly boys in Australia, and results in early death but significant disability, access, a 1 or 2 year delay will have lifelong consequences. So there is a lot of anxiety, but the costs of these programs, these new treatments at around $2 million, obviously present, even to a country of Australia's development, a significant additional cost to the health budget. So in terms of where we're up to, 2020 has seen a lot of change in Australia, and a lot of action in this space. We saw our first ever strategic action plan released in February, which included some really important, I think, recommendations, particularly around the centres of excellence. And even in Australia, there is a huge disparity in people's access to diagnosis based on where they live and whether or not the physicians at the local hospital have a background in the disease or not, and then in the treatments that people receive. And so centres of excellence offer, I think, a really important way and an almost critical, I think, development to ensure that everybody within the country can have access to that expertise. In July, also really importantly, we had a new National Health Reform Agreement, which included financial and governance arrangements to ensure access to new gene therapies. So the idea being that this will be done through our public hospital system, and people will be able to gain access to new gene therapies that are approved centrally. Now, there is not a lot of transparency around how that process is going to work, and I think that is something that needs to be sort of worked through and more assurance is given, because I think there is some worry that a certain hospital might approve something and might fund it, or one jurisdiction within Australia's state system may fund a therapy but another will not, and so we might have this real inequity across the states and across hospitals potentially about who is getting access to these vital new therapies. And then in August, I think, reflecting how much is changing in this space and the need for government to respond, we had a new parliamentary inquiry launched into those approval process for new drugs and novel medical technologies in Australia, that I think is going to look really at rare diseases and both the orphan drugs and also the gene therapies in a more holistic way, and see how can we reform the processes to ensure that Australians do get access to these new therapies and they get access to them in a timely way. And it will be interesting to see what comes out of that inquiry. There is some very committed politicians in Australia on both sides, both the sort of the conservative and the progressive side of politics, who are on that inquiry, who've had a long history with rare diseases. And I think it's got a real prospect of providing, I guess, in a very changing landscape, the sort of reforms that perhaps Australia could really benefit from, and Australians with rare disease. In terms of, I guess, sorry, going backwards, the unresolved issues, it really is that idea that the government has remained committed to the HTA and very firmly committed to the HTA processes for rare diseases, and whether or not that is provide that level of inflexibility is going to really hinder access going forward. There's still no real secure funding for new therapies. So this idea of the trust fund, or even any sort of secure funding in terms of will the government provide that fiscal room for these new therapies or not, it isn't clear. And there are significant issues, particularly for Australians at the moment, around the clinical trials and the approvals for new therapies, as particularly gene therapies, where the processes really aren't set up for that access, and that is one area of particular concern. So thank you very much. In terms of next steps, I really encourage you, and I will send through to ideas the outcomes of the inquiry, because I think it's likely to provide the real foundations, hopefully, for the next steps in Australia. And just for an overview, you can see our reports on rare diseases at our website, Equity Economics. But thank you very much.
Thank you, Angela, for that excellent presentation. So fellow friends and colleagues, if you have your question, please keep it coming. As you can see, the question and answer box is actually quite active right now with some questions going in, as well as some answers that have already been provided by ideas. Now, what's going to happen towards the end when we have the panel session is some questions, despite the fact that it has been answered, will be lifted out so that other people will also be able to benefit from the answers. My next panelist is Professor Nathorn Chayakunapruk, who is now a lecturer with the University of Utah, a professor in the Department of Pharmacotherapy. It is my pleasure to introduce Professor Chayakunapruk, who earned his doctorate in pharmacy from the University of Wisconsin-Madison and his PhD in pharmaceutical outcomes research and policy management from the University of Washington. Now, his expertise is in HTA, health technology assessment, and his applied HTA methodologies from health economics, real-world data analysis and evidence synthesis, systematic review and classical network meta-analysis have helped to support national and global policy, especially in his contribution to the World Health Organization. His research is in broad areas ranging from infectious diseases, non-communicable diseases, community pharmacy, immunization programs, complementary and alternative medicine, pharmacogenomics, and smoking cessation. His recent projects have been focused on snakebite burden, cannabis, fatty liver, anticoagulation, and Alzheimer's disease. His research has been funded through grants from WHO, the Wellcome Trust, the US National Human Genome Research Institute, and the National Institute for Health Research, UK. Dr. Chayakunapruk has an age index of 29 and is an author of more than 180 internationally known publications and peer-reviewed journals. Now, this, of course, includes the Lancet, the Annals of International Medicine, Cochrane Database, etc. Now, he currently serves as the co-editor of the Value in Health Regional Use Journal, Pharmaceutical Policy and Practice, the Cost Effectiveness and Resource Allocation, Phytotherapy Research, Journal of Medical Economics, and is the member of the editorial advisory board of the Journal of American Pharmacists Association. Now, Dr. Chayakunapruk will be sharing health economics of rare disorders in Thailand.
Hi, good morning, everyone. Can you hear me well? Can you see my screen? I assume that you can.
Yes, we can hear you well and see your screen. Thank you.
Thank you so much, and thanks for introduction, and my pleasure to have a chance to share my expertise and experience on health economics of rare disease in Thailand. Before I get started, just to disclaim a little bit about myself, I was a National List of Essential Medicine member on Health Economic Working Group and also was an advisor on National List of Essential Medicine in various periods of time. I was a member of Universal Coverage Benefit Package Committee under the National Health Security Office in Thailand before I moved to the University of Utah. And I also had a chance to work on the cost effectiveness of immunoglobulin used for treatment of dermatomyositis and CAPD, which is a kind of rare disease a little bit as well for the National List of Essential Medicines. And basically, I have interest in rare disease, and that's one of the reasons I have been involved with some research on that and involved with the national decision-making involved with on the pharmaceutical benefit package in Thailand. I like to talk a little bit about Thailand and decision-making process and the use of health economics to support decision-making. As you all know, that Thailand is your neighbor, not too far from Malaysia. We have 65 million people, and we have universal health coverage established since 2002. And basically, the health expenditure is about 4% of GDP. And we have three main health insurance schemes covering 100% of population, including the first one, which is called Civil Servant Medical Benefit Scheme, cover roughly about 10% of population, which is basically for government employee. The second one is Social Security insurance, which basically cover about 13%, which is for private sectors. And the last one is universal coverage. basically covered the rest of the whole country, about 74%. And in order for the whole government to have a single system to help making a decision for all three health insurance schemes, there has been like something called drug benefit package of 3 schemes that will be based on any drugs listed in National List of Essential Medicine. And of course, orphan drug is part of that. So today when I talk about Thai benefit package, I would like to think about it from 2 sides, pharmaceutical products and non-pharmaceutical products. In fact, rare disease and orphan drugs are involved for both. For the orphan drug itself, it would be considered pharmaceuticals, when non-pharmaceutical is more like a rare disease management, including screening, referral system, everything that. So basically we need to understand both. In terms of National List of Essential Medicine, which is on the pharmaceutical products, generally speaking, it starts with 23 experts, 23 expert groups that ranging from cardiovascular, oncology, GI, dermatology, and also rare disease, which basically look at any particular products from the efficacy and safety. And then when the product feel like, yeah, it's important, have shown good efficacy and safety already, basically it comes to the screening groups that try to look, well, whether do we need to have information in terms of cost effectiveness or any other aspect that need to be considered. So if you look at the box on this right-hand side, which is the health economic working groups, which I used to be part of the member, basically consider the economic aspect of our products. In this case, in Thailand, we have considered, regardless of whether it's rare disease, orphan drugs, or any innovative products, or any kind of products, including gene therapy, need to be considered by health economic working groups if they meet a certain criteria. For example, the budget involved with that, or maybe the likelihood to cause, a substantial budget involved to the whole country. So that kind of committee consider health economic aspect, which include cost effectiveness analysis and also budget impact analysis, and provided information to the National List of Essential Medicine Subcommittee, which is the last committee to make a decision. This slide showed that there are lists of several products that have been considered in Thailand for National List of Essential Medicine, and we have a cutoff of basically 160,000 baht per quality to be considered cost effective. And you can see from the green area that any products that have an ISR, or basically incremental cost effectiveness ratio, less than 160,000 is considered cost effective. But anything below that is not cost effective in general. However, I would like to highlight 2 groups of products. The first one is renal replacement therapy, which is not cost effective, and also imiglucerase, which is treat for Gaucher disease, which is not cost effective as well. However, even though it's not cost effective, it has been included in the benefit package of the National List of Essential Medicine. And we'll talk about that with details more about Gaucher disease. But for peritoneal dialysis and hemodialysis, they were included because they're concerned about catastrophe associated with the use of renal replacement therapy that incur by people in general if we do not provide this kind of renal replacement therapy as part of benefit package. So basically the government not only consider health economics, they also consider other aspects which we think is important to help them make a decision whether we should include that particular products or interventions as part of benefit package. This is kind of the process for non-pharmaceuticals, which talk about the health technology assessment can be nominated, prioritized, and then perform health technology assessment and appraised to help support decision making. I will not go into that in details, but I would like to highlight the fact that the cost effectiveness analysis and budget impact is very important. So I would like to use the next few slides to talk more particularly on the health economic of rare disease. This is an example that is very important, which is on the imiglucerase for Gaucher disease. And basically it was a study that has been done, I think around 2013 or 14. And the results showed that it's not cost effective. basically 6.3 million baht per QALY, or basically 100 more, like a lot more than 160,000 baht per QALY, which is a threshold. It was specified as reasons to include this product in the national list of essential medicine, despite the fact that it is not cost effective, based on the following reasons. The first reasons, they said because it's rare disease and budget impact analysis is likely to be manageable, and it's only 5 people. And the disease is kind of, even though it's terminal, but it's curable through the bone marrow transplant. Basically, patients who undertake bone marrow transplant need to take imiglucerase for 1 year before undergoing transplantation. And they also said that if imiglucerase were not included in the list of essential medicine, BMT, which is currently under universal health coverage benefit package, would mainly be available only for someone who can afford imiglucerase, which may be only the rich. So if we don't provide imiglucerase access to people, it will basically increase disparity. So the interest of considering the equity issue has become one of the reasons for supporting the decision to include imiglucerase into the national list of essential medicine, even though the product is not cost effective. So this triggered potential interest to consider, what kind of health technology assessment system should be performed for orphan drugs in different directions from maybe should we do it differently from other interventions? Because some people say that, hey, we have spent like commission research to do it and it is not cost effective, but because budget impact is not much and we decided to adopt it, maybe next time, do we need to include it? Do we need to do cost effectiveness analysis? Is still has been brought up, but nobody have really set up that, hey, we should not do it. We still have no different benchmark on how to do health technology assessment for orphan drugs yet, but policymakers start to think a little bit differently and say that maybe it's obvious that we should not consider only health economics or cost effectiveness analysis as the only important factor to drive the decision making. I would say in the last few years, there have been more of the rare disease awareness, and basically 2020, the same as in Australia, is a big year for rare disease awareness in Thailand. This is the event in February this year, just 1 month before COVID-19, that this is kind of rare disease, that we need to do something to help people in our country. And basically, it is kind of important to point out that Universal Health Benefit Package has announced in 2020 that rare disease management will be a key policy for us to move upon. And basically, we start with 24 main rare diseases, which basically provide a system for rare disease screening and referral system, and they set up 7 major hospitals to take care of that. So it comes again with the human resource on expertise. We have, of course, limited to a certain hospitals or provinces, and the whole country try to set up a system to help referral those patients to seek care properly. And in addition to that, the National List of Essential Medicine, I think I would say about 4 or 5 years, have recognized the importance of rare disease and have one of the working groups, as I said, out of 23 National List of Essential Medicine expert working groups. One of them is a rare disease expert. So it's obvious to say that the rare disease management is important and has been more recognized globally. And a couple of years ago, with Asru, the first speaker, and also our Suwana, our PhD student that I was co-supervisor, basically have kind of looking at the overall landscape of the rare disease management in Southeast Asia and try to summarize what can we do and what should be done in order to help improve the system. And one of the things that we think is a regional cooperation is important. And we have proposed several things in terms of try to promote the system that can help ASEAN countries to think about how to manage the rare disease and clinical services, and even more research consortium or system to help for that. And one of the key problems is about funding and welfare. It is to make it sustainable, which is basically one of the key issues that we need to discuss today. So I would like to end my presentation to recognize the importance of rare disease, and is something not only in Malaysia, not only in Australia, but also in Thailand that we see the importance. And of course, economic aspect is one thing that has been considered, and there has been strong consideration of the rare disease. Even though we haven't had a clear plan yet, whether health economics or cosmetics is needed to be used, but I can see myself, this is only my opinion, I can see the trend that the decision should not be driven by only cost effectiveness analysis. There are some other aspects to help with that. But of course, the issue of funding mechanisms need to be discussed, and I'm looking forward to having a discussion in the panel. So thank you very much. So the floor is back. Thank you.
Thank you so much, Dr. Chayakunapul. I love the last message that you sent, that we should not be looking at healthcare financing solely on a myopic or a narrow lens, and that a lot of other things should be put into consideration. A lot of things also should be thought about when we're looking at healthcare financing for a country. Now we have approximately 25 minutes before the bewitching hour and the session ends. Before that, I would like to invite all of our panelists back. So our A team is back here. We've got Dr. Chayakunapul, we've got Lawrence Todd, we've got Angela Jackson, and of course we've got Dr. Asrul Akmal, and together we will be having a panel session where we will be opening up the floor to questions. And the topic of discussion today is sustainable financing options for rare disease therapies. Of course, we also understand and appreciate that the issues surrounding rare disorders in any country for that matter is complex and cannot be summarized in just one session sitting alone. In fact, when we were talking with ideas prior to the forum itself, we acknowledged so many other things, including lifelong assistance, womb to tomb trust funds to care for aging caregivers, and lifelong needs, independent living. So specific to orphan drugs and the options that we have for sustainable financing, I now open the panel to the questions that we have. Okay. Now, there are some questions that were originally answered by Lawrence and team, but for the benefit of everyone, I will lift some of these questions up as well, because I believe that not everyone is able to see the question and answers. Okay, so first up, there have been, of course, a healthy amount of question with regards to the role of pharma companies and what they bring to the table, especially to the attention of the Ministry of Health to improve faster access. Now, Suki, along with Tai and a few other members of the forum also asked, for example, how can patient action groups work with pharma companies to bring attention to the Ministry of Health to improve faster access? This means from registration to the formulary listings and funding of rare diseases. I'd like to open this up to Lawrence as well as Dr. Asrul, and of course for Angela and Dr. Nathorn to pipe in as well.
Thank you very much, Nadia. Sure, I think I probably got maybe a few things to say on the role of pharma in the industry. I think maybe we can think about it in three ways. Like, I think we have to think about drug development, we have to think about pricing and reimbursement, and we have to think about awareness raising. So I think when we talk about drug development, I mean, I'd be very interested in Angela or other panelists' views on that, because, you know, I think the point is that what we're dealing with is an international industry. And so the incentives and the way that market is structured is a global market. So I'm not sure that Malaysia actually has that much locus of control over how those incentives are shaped. So I think we can have a very long-term strategy around building up the capacity of our domestic pharmaceutical industry. And I think at the same time, we have to develop regional collaboration, and that's something we're going to talk about more tomorrow, in order to play a role in shaping that global market. But it's quite difficult, I think, for Malaysia unilaterally to do a lot to shape the drug development environment. Okay, so that's on drug development, and we can delve into that a little bit more, and maybe the other panelists can challenge my assessment there. The second point is on the reimbursement. So I think that there's a couple of things that we can do to improve that. I think it's quite difficult for me as an outsider to kind of fully unpack the process that the Ministry of Health goes through when it negotiates, or when it decides on listing things on the formulary and procuring drugs. To me, I haven't looked at that in great detail, but I do see some potential improvements that can be made in the areas of procurement, also in the areas of like the way we negotiate with industry. So potentially looking at different modalities, so more efficient price volume agreements, maybe looking at like longer term licensing, so there's a more certainty in terms of the uptake of certain drugs in order to lower the unit price. So there are potentially, I think, improvements that could be made, but with the caveat that it's quite opaque to me how that works. But I do think there is ways in which that negotiation process could be strengthened. And then I think linked to that is the capacity building through regional collaboration, which again, we're going to talk about a bit more tomorrow. I also think that the patient access agreements that work with where the pharmaceutical industries provide access, particularly I think, for kind of particularly vulnerable patients, although pretty much all the patients we're talking about here are vulnerable. I think there's been some recent guidance to improve the structure on those. So I'm not sure how that's played out. But one thing that I suggested before was looking at trying to create incentives for the pharmaceutical industry to do more on the patient access agreement side. So maybe rather than look at trying to get the corporate sector to donate money and have tax incentives for that, you could look at tax incentives for pharmaceutical patient access agreements. So I do think there's scope to kind of have more efficiency and gain something there. Then I think finally is on the awareness raising. So that's that last point that you mentioned. Look, I think that doing activities and participating in events like these, and I think the pharmaceutical industry has demonstrated some willingness to try to support just generally the environment for discussion on these issues. So I think take advantage of that wherever you stand kind of in the ecosystem here, and use that as a platform to raise the attention to the Ministry of Health. Yeah, but I see a lot of that happening across the patient groups in the different ways, using their different skills. So, okay, I'll pause there.
Now I'll do a follow-up question to that. Perhaps I'll open the question to Dr. Asrul. Now, following up from what Lawrence mentioned earlier, now, do we know of any, I don't know, I suppose, innovative business models that can incentivize pharma to develop or at least market new drugs without costing an arm and a leg for the patient groups? This question is from Tai.
Well, drug development is certainly a very expensive process, and also it's not easy to find a good candidate for a drug, and you do need to give them a certain level of incentive for them to develop the drug, which is why I think we have such an incentive for pharmaceutical company to actually keep on developing drugs for these rare disease patients in a few countries, for example, in the States, which actually help to make sure that we have a drug for rare disease patients and for it to keep on coming. Because previously, I think a few decades ago, I think there are only very, very few drugs for these rare disease patients. And with this Rare Disease Act in the States at that time, there has been an increase, and now with a proper incentive, which would allow them to keep on putting times and resources to develop this drug for the rare disease patients. So this is one of the cornerstone of the strategies for us to improve access, where we can actually increase the supply of the rare disease medicines. So how do we actually make sure that we can actually give them this proper incentive? So this is perhaps beyond the Ministry of Health. I think the Ministry of Health has to actually liaise with the MITI, the trade industries, ministry in order to actually come up with with a good incentive for the pharmaceutical company. On the second part of the questions, which is actually the first part of the questions that I think was it Sui who asked, and Lawrence were responding just now. And I think I agree with Lawrence as well. There are a few things that the pharma companies can help. I mean, number one is actually to take up any incentive offered by the government or the international bodies, and also perhaps try to extend the trials to also recruit patients from Malaysia. And that will actually help to improve access to these medicine, even though perhaps it's experimental, but also increase the sample size and also the generalizability of the studies being submitted to the Malaysian authorities. And that is certainly the most important part, which is being a big barrier for the public agencies in Malaysia to approve, either to register or to cover the drug in the Malaysian public health system, because they feel uncertain about the documentations available for the drug being submitted. I think for that case, then what Lawrence said, and I would like to expand on that, is that maybe the pharma company can work hand in hand with the Ministry of Health to come up with a proper market entry agreement where you can have sort of like a conditional coverage. So for a certain time of periods, the government will be able to support a certain number of patients, but at the same time that the company have to make sure that they monitor the outcomes for the drug on the patients that have been receiving it, and make sure that what been promised earlier can be achieved at the end of the time. And that is a sort of like building up the confidence and also building up the evidence to actually improve all this anxiety by these public agencies. Thank you.
Thanks for that. There's quite a few things to unpack there, because obviously the issue is not one that is straightforward. I wanted to pick on what Lawrence said earlier, but now address the question to both the good doctor and Angela. When we're talking about regional collaboration, we know that during the APAC CEO Summit in 2018, there was already an official launch of an RD action plan for APAC economies, and there were 10 key areas, big ambitious targets, and he's actually included some of the things that Lawrence mentioned in his policy paper: raising the bar on public awareness on RD, better use of technology to enhance purposeful use of data in clinical decision making, and of course healthcare system designed to ensure that patients are diagnosed and cared for in a timely manner. Now that line triggers the question that Dr. Chaya Kunapruk mentioned earlier, this whole issue of cost effectiveness and really equity towards life-saving drugs. So for both in the experience of Australia and Thailand, could you share how your governments have managed to really weather the minefield where you have a situation where we're very clear that the number of individuals who will benefit from such an intervention or life-saving drug is far and few in between, especially now in COVID-19, where I would think that the needs of the rare disorders community will become second priority to emergency public healthcare. So in COVID-19 and beyond, what do you think are the strategies of your government in prioritizing RD as well as life-saving drugs?
Yes, I can start answer that question first. As I mentioned before, that this year is a special year for Thailand that recognize the importance of rare disease, and what they try to say that they have more like a launch of pilot hospitals, basically 7 hospitals that work on the referral system. But you know, this kind of things Rome cannot be built in one day. It takes time to develop the network and system through the traditional way. But one of the things that I'm not sure in details about this, but I thought that if we use more like a telehealth or other kind of new technology for communicating and networking, it may help the system to help us better diagnose or screen the system better. And it's not necessarily only need to be done within only Thailand. And that's why the issues of regional collaborations and even share resources, because expertise in this, of course, we have several, should not say thousands of rare disease, and expertise in only one country may not be sufficient, and the system that need to be merged together. That's one thing that I like to, I think that's very important. And I think at least the awareness has been raised for each country, but how this can be linked and make it the whole system of the region, that is something need to be moved forward. That's the first thing I like to talk about. The second thing that Dr. Asru just mentioned about managed entry agreement, can I get back to that issue a little bit? I was gonna try to say before, but basically that's an example of how a product imiglucerase has been deal between the government and the pharmaceutical industry. So there have been an agreement that only the first 5 patients, this is the price and this is the kind of things that government will be buying from you. But if anything beyond that, we need to deal with it. And with the expectation that this patient will be eligible to go for transplantation, and we need to look outcomes and quality of life, whether they have been switched and moved to transplantation. So that kind of agreement to help making sure that it's not just only patient have access and yeah, I'm done with that. We just want to make sure that they have a good outcomes and have reasonable budget and all things that can be managed in the longer term. So I think that kind of managed entry agreement, if it can be implemented successfully, which it was successfully, but at this time, it has been seriously scrutinized and evaluated. I don't know exactly what are the process, maybe because I'm not updated on the results, but it was discussed seriously in early 2019 before I left for the US. And I'm sure that there may be some progress already on that. But the ideas of managed entry agreement is the one of the ways to help improve patient access on this. Thank you.
Angela, would you like to pipe in?
Yeah, look, I think it's interesting, and in terms of, I guess, the Australian experience, what we've found, I think, is in terms of what pharmaceutical companies can do and how the political landscape has evolved, is that really having a peak patient body and rare voices has really helped. So that has been partly funded by pharmaceutical companies, definitely, but it's independent, and it's provided a single voice for people with rare diseases across Australia, and push for that systematic reform, because I think often, you know, when it's one disease at a time, governments can sort of make decisions, but it doesn't necessarily solve the wider problems. And then the issue in terms of getting the change at the political level, it isn't the Department of Health, I don't think, it's really the Department of Finance and your treasuries. What they don't like about drugs and about rare diseases is that they can't really, the uncertainty around the benefits, but also the costs in particular. And I think the history in Australia of very fast increasing drug costs, they don't like that. They don't like that inability to manage and to foresee and to know what is coming. So I think that's where the managed entry schemes, I think, are important, both from in terms of the benefits, but also what the costs are going to be, because that gives everybody in the situation more certainty. And also the pharmaceutical companies, that they know their drugs are going to get funded. Because obviously that's, from a development point of view, what often stops pharmaceutical companies spending that extra $1 billion or whatever it costs to get a drug to market, is the fact, will anyone fund this if we do it? So certainty really is, I guess, the really thing that really undermines these treatments for rare diseases, because we can't necessarily predict with a lot of certainty the benefits, and then the costs are also quite uncertainty. So whatever you can do in the arrangements or the way you approach things to increase that certainty is really, really helpful. It'll be interesting to see where Australia goes in terms of next step. As I said in my presentation, there has been, I think there was a question, why has there been this hesitance? I think system history is a big part of it. We've had a lot of success with HTAs. There's a lot of pride in developing HTAs, but there hasn't been a lot of I guess, innovation in Australia's health system over the last 20 years. We sort of did Medicare, we did these things, it was very reform focused, but then it sort of stopped. And there is therefore an inability, I think, to take on new ideas that, other jurisdictions clearly do. Like in the UK, NICE is a much more innovative body and it's prepared to try new things, whereas the Australian system isn't as prepared. I hope that changes, but at the moment it's sort of still stuck very much in what maybe worked 20 years ago but isn't going to work for rare diseases.
Thank you for that. While I know that a large focus of this discussion is focused on orphan drugs, regional collaboration, and the cost effectiveness of things, I really wanted to be able to take time to also zoom out the concept and unpack this issue that health equity, or in fact the right to life and the right to flourish for all individuals, not just individuals with rare disorders, is really a matter of womb to tomb. So very often when we talk about rare disorders, some of the very common things that we hear in the news, in the media, that's being bantered through either political discussions on policy, is all about the expensiveness of rare disorder, orphan drugs, and that issue of being able to only benefit so few for so much money. And I really want to dial that back, because clearly we're not doing justice in the communications aspect of what rare disorders patients and their families actually need. The good doctor earlier mentioned that for the Gaucher diseases, although there are treatments now, imagine if you did not intervene in a timely manner. And I like to quote timely because Prof. Tong, our dear Prof. Tong, often talks about this, where we're talking about managing cost effectiveness thresholds, and perhaps using a more multi-dimensional criteria in ascertaining a broader view of what exactly is value for money. And I think we haven't fully unpacked that. We know for a fact that in the world, there's only 5% of rare disorders that have treatment. I belong to the Phelan-McDermid Syndrome Foundation. There is no treatment for Phelan-McDermid syndrome. And very often when we're sitting in this discussion, representing other rare disorders who do have a chance at life-saving drugs, it really pains us to see if there are people who are able to be saved, why is this not the case? When we are, Malaysia is a signatory of the SDG, and SDG already, SDG 3 in particular talks about good health and well-being. So I want to ask you in particular to what other mixed funding modalities that we can use to supplement already existing stressed out coffers that we have. We know that COVID-19 is not going to go anywhere. I'm not too hopeful at the state of budget 2021 and what it would be able to do for the rare disease community in Malaysia. But when we talk about right to life, when we talk about right to the quality of life, if we're talking about CSR funding, as Lawrence rightly pointed out, I'm not too convinced that that would be enough or sufficient to be able to support, because we know that in Malaysia, the Tax Act 44(6)(H already has allocations on what can be done or tax exemptable for CSR, but I still feel that that's very narrow. In some of the countries in ASEAN, what are some available tax exemption options to perhaps entice the corporates to not only look at orphan drugs, but maybe tools, equipment, hope, really, assisting in things like access to employment, access to education. These are all needs that the rare disorders community require and may not necessarily cost millions. Thoughts, please?
I mean, I can certainly jump in on that. There's a lot to unpack there. Look, I think it's really important that we're clear about this point around kind of orphan drugs versus the wider rare disease landscape. And I think, to me, it's very important that if we go down the route, for example, of a trust fund, I think that's why it's really important to define that scope very clearly. The reason we always come to the orphan drug discussion is because from a policy perspective, for like policy wonks, like me or whatever, it presents a very unique challenge for healthcare financing, and therefore it tends to be the bit that attracts the most attention. But let's be very clear that there are gaps across the whole landscape in terms of access and in terms of the level of treatment. There is not enough testing, there is not enough screening, there is not enough early interventions like food fortification, there is lack of access to non-orphan drug treatments, there's lack of access to lifestyle adaptations, there's lack of access to psychosocial support, there's lack of access to carer support. All these things are gaps. And that's why I think it's very important that when if we take this approach of a trust fund, we're very clear, because actually patient groups are raising money, as I mentioned in my presentation, to pay for tests, right? Now, is that something that the trust fund is going to take on? Because in my view, actually, the reason that orphan drugs is important is because it challenges the sort of way we think about HTAs, right? So in my opinion, when we talk about screening and testing and food fortification, these things should be judged as, these things are already demonstrate value for money or cost effectiveness, and therefore should be supported in the public healthcare system. So in a way, it's like this kind of two wrongs make a right thing, right? Like, oh, well, orphan drugs are crazy expensive, so we need this different financing system. And then that takes the attention away from actually filling in all these other gaps that should be filled in anyway. So let me be very clear. When I talk about trust funds and things, I think it's, to me, that is completely in the context that the financing of orphan drugs is a very legitimate international policy challenge. It is certainly not the only challenge in the rare disease landscape, and all those other issues that I mentioned, which should also be addressed. And we need to be very clear, if we do take the approach of a trust fund, whether or not it's the responsibility of that trust fund to also address those issues. And actually on that, my opinion is it shouldn't be, because those things should be addressed through the public healthcare system. Okay, the last point I'll make on this is that it does also depend, some of this also gets tied up with where Malaysia is going with its healthcare system generally. As I signaled in my first slide, actually the public healthcare through MOH accounts for about 40% of expenditure. You know, this is not the UK, like my own country, where the NHS is like 90%. You know, the public healthcare system really is healthcare. So whether or not, and I feel like there's this reluctance generally in the Malaysian government to really back universal public healthcare as the model for Malaysia. And it's trying to develop private insurance, trying to develop SOXO. So it's kind of backing a few different horses. And I think that's where it makes it more difficult to tackle these difficult challenges. So if we do want to go for private insurance, then there are, I think, options straight away we could do on the non-orphan drug issues like testing and screening, for example. Social insurance, there are low-hanging fruit, expanding My Salam. There are these options, but I think at the core is okay, what kind of healthcare system do we want to have? What are some of the principles? You know, you mentioned rule of rescue, non-abandonment, equity. How do we want to finance that across the whole piece, which, you know, I think involves greater levels of taxation to expand the public healthcare system. And then within that, we can accommodate rare diseases. So the problem is when we talk about orphan drugs, we're kind of fixing one problem in a whole landscape of problems in rare diseases. And when you talk about rare diseases, you're talking about one problem in a whole landscape of problems, which is Malaysian public healthcare. So I think that it does make it a challenging context for thinking through policy. But that is why I just sort of make that very clear that that is definitely the context and the way I approach the issue. So it's good to be pulled back from getting into a very wonky discussion about how you reconcile HTA incremental cost effectiveness ratios with orphan drugs and because that's where we always get pulled into. But absolutely, this sits in the context of nested problems that also have to be addressed. So that's my kind of piece on that.
I love the candidness. Thank you for your honesty. The rest of the panel, would you like to weigh in on that question? So of course, we can see the chat going, thank you, Lawrence, with like 5 exclamation marks behind it. So would anyone like to add on?
I'm happy just to add, I think, just one thing, which is around, I think, your equity point, which is, I think, often when we talk about cost effectiveness, we don't identify that it's a utilitarian approach, that we're about maximizing healthcare. And so it's got an equity dimension there, you know, people are equal, that sort of horizontal equity, but it doesn't have vertical equity. And to make that clear to decision makers, what's underlying, what is quite a complex idea. And I think we're all happy that they sort of get that there's this quality and, you know, there's value here. But underlying that is a lot of theory and a lot of assumptions that they might not necessarily always buy into. Like if you said, you know, if we can have a very small benefit to a large number of people, but we would value that equally to saving one person's life, most decision makers would go, oh, well, wait a minute, I think those 100 people can do without if we're going to save this person's life over here. But that's not what the quality framework does, right? It doesn't necessarily, you know, allow those judgments to be made. That's a human judgment, which with COVID-19, what we're seeing is, you know, in Australia, in Melbourne, we've just finished a 4-month lockdown, which has really been about saving the lives of older Australians, right, effectively. And we have shown that, you know, the whole of Melbourne has been prepared to have 4 months without really seeing anyone, and gone through a lot of struggles and a lot of economic costs, to, you know, a small, I guess, cost in a sense, but to save the lives of others, so that actually society might not necessarily view the QALYs the way that we as health economists view it. And I think explaining that to decision makers helps get through that idea about why rare diseases need to be treated differently.
That's a very important point, Angela, because very often, if it's just merely a numbers game, we don't see that. Dr. Chayakunaprok also mentioned the fact that if you do not address the issues in a timely manner, you're talking about lifelong further complications and issues in just ensuring that this individual is alive, or will then have to pay for more costs that would have to be managed. We have passed the session at 11:30 by 6 minutes, but this is such a rich discussion. I would like to seek the permission of the beloved audience if we can extend for another 10 minutes or so we can very quickly pull together some of these questions. If you do have to leave, we understand, but if you can spend another 10 minutes with us, we will make it worth your while. 10 minutes? Can? Yes, please extend. Okay, great. So, all right, sure, please extend. Would it be okay for the presenters, just in case you're running off to save a life and we're taking you away from something really important? All right, very quickly put, we were talking about healthcare financing, not only in Malaysia, but also the region. And of course, the two countries also gave their views on what has been the case in their countries. Lawrence, you said public healthcare expenditure is only accounting for about, well, 50 now, 40% of the total health expenditure in Malaysia. But out of this, if we drill that down, right, relative to the size of economy of Malaysia, this public expenditure of healthcare is only about, what, 2.35% in 2019, which was approximately, if I get this right, 0.09% increase from the previous year. And this was, of course, following the manifesto of Pakatan Harapan government to increase healthcare expenditure to 4% of the GDP. We are not there. So the question is, what do you forecast is going to be what we would have to contend with? On the one hand, we know that there's the drugs issues, there's the formulary issue, there's the access to available resources. But at the same time, there are other areas in which the rare disorders community may be able to tap into that we are unaware of. Could you share a little bit about your thoughts?
Yeah, I can just very briefly on that. I think that, I've shared my own view that I think Malaysia should expand its public healthcare system and invest in it. And I supported the Pakistan promise to try to reach 4% of GDP on public healthcare expenditure. That's not something, as you said, that they were able to do. And we're on quite a slow upwards trajectory on that front. Look, I mean, not to get sidetracked into another discussion, but I mean, we're going to have a conversation about taxation and about the level of tax that Malaysians want to pay to have public services.
We want efforts, but we don't want tax. That's the problem, right?
Well, there are other options, right? We can talk about private insurance-led healthcare, and there's pluses and minuses to that. Some of the best healthcare available in the world is in the United States, but equity isn't something it's known for. Or we can talk about socialized healthcare, which is kind of more common in APEC, where we see like Taiwan, Thailand, I think. I mean, I'm not Professor Nathan on this, but I think Malaysia might be able to do more, but SOXO, and EPF, they're nowhere near that yet. So we need to take a big step with those models. And I think that is holding up this RD discussion a little bit because the government can always, push it off. So I think we do need like broader healthcare reform, and at its core, that's a decision about what kind of healthcare model we want to have as a country, and then take the bold decisions to finance it. And then as part of that, we can get a real settlement for rare diseases across the whole spectrum of challenges that we've identified.
Can I say on this a little bit? I just want to concur my thought and emphasize the importance to think about what we need and then go for it in the right direction. I'm not saying that we should go left or go right, but it's become very challenging when you say that, yeah, I want everything, but I don't want to invest, but I want to invest something else. I don't know. So it's important, and of course, when we talk about this is, and in order for any kind of, many of us to help kind of brainstorming and ways to go, it might not even fit it because the policymakers or the decision maker may not be willing to take anything because things haven't been crystallized in terms of the way to go. Thank you.
Thanks for that. Prof. Asrol, Angela, would you like to add in there?
Yeah. I think definitely government cannot use the trust fund or foundation or whatever to wash out their hands from a rare disease. Definitely, it's just a way for us to make sure that the patient receiving what's being needed. But at the same time, what Lauren says about reforming the healthcare, that is something seriously need to be done. I think it's already on the government plate for a number of years. It's one of the biggest issues in Malaysia why we cannot push for the reform is, of course, the political certainty that we have in Malaysia. So whatever we're trying to push in terms of innovative funding or perhaps regional collaborations, so that need a strong political will. And I take notes that we do have some senators which is a bit vocal lately, Senator Ras Adiba, who has been talking about rare disease in this August House there. And perhaps we can actually give support to all of these voices that we have in the government, so that then they can keep on pushing the agenda, but at the same time not forgetting the reform that need to be done to make sure that we can actually make sure that the agenda being realized at the structure level.
Thank you for that. And that very nicely brings the conversation, I think, almost full circle. While we're talking about mixed funding modalities, while we're talking about policy, we're talking about the big overarching issues that need to happen. What I hear from what you're saying at the end of the day is at the crux of it, it's not just about the government ensuring that there is funding. It's not just about the pharma trying to reduce their costs or working their ways around it. It's not just the formulary working on health, technical assessments and economics. But at the end of the day, the patient action groups themselves must continue to push on and find a way to somehow speak in a united voice. Now that is a huge challenge that we have seen over the years, naturally so, because we're all at different phases of our journey. While some are pushing aggressively for life-saving drugs, others are trying to push for access to employment, others are trying to push for caregiver respite, and even bereavement and grief. We now even have groups that focus on caregiver psychosocial mental health for those that have lost their loved ones. Really, for those that are part of the rare disorders community, this is not just a policy paper. This is not just an act that's going to come out or a nice little anecdote or a bullet point in a budget. It is our life. So it is something that we do take very seriously. Of course, our dear Dato' Hatijah has also mentioned a comment in the section, so I'd like to read this out. RDAFM was meant to be registered as a foundation because we cannot afford to register the organization with ROS and SSM because there is a cap to the amount that needs to be in the coffer before that. So we therefore registered with the Prime Minister's Department. Thus, we had to be named a foundation. We can receive funds for other purposes except monies for treatment for RD. Now, one of the things that, thank you, Dr. Hatijah, for that, as well as the fact that while you have mentioned that Singapore's RDF focuses on orphan drugs, and perhaps for some countries it has worked where the endowment fund or the trust fund is more focused in its call to action or what needs to happen. Perhaps in Malaysia, like what Lawrence mentioned earlier on, there might be more than one structure that is needed, one focusing specifically on access to equity in drugs, and perhaps the other on support services, lifelong things like access to education, etc., which can actually be advocated together with other persons with disability. So there are specific things that are specific for the RD communities, and then there are others that might be something that, like you said, Prof. Asrol, the force is in numbers. So if we can rally around topics that are universal, that is the right of everyone, perhaps we will not get boxed or branded. So for me, it's about being nimble, do whatever that works within the frame of being respectful to all of the different needs that are available. So my final question to all of you in one sentence, how can patient action groups work better together in coming up with a unified voice to champion for change and hope?
Wow. Well, I think, I don't think there's anything that I can teach the patient groups about what they do best, which is to advocate for this cause. I think, I certainly have learned most of what I know about these issues from the patient groups themselves. So, but I think to keep doing what they're doing and provide that platform to advocate for the issues. And I hope that, we can, I think it's these kind of partnerships that this conference represents, between people who work on policy, people who are health experts, people who are representing patients and other interests to kind of come together and thrash these issues through, and then just kind of keep sharing that input with the government. So that probably wasn't one sentence, but that's my kind of final message. Thank you. Oh, and last thing, so sorry if I didn't get to answer all the questions, there's quite a few questions. So, but we're also doing the session tomorrow. Yeah, but thanks everyone for the input. It's really helpful.
I'll just say from my experience in Australia, it really was that single and very effective voice through Rare Voices that has been able to bring together all the groups and the leadership. And so that's always the X factor. Do you have that person? And I know in Australia in the last 5 years, we've had Nicole Millis, who's the head of Rare Voices in Australia, incredibly effective advocate. And finding that person effectively who can bring people together and have a really credible voice to government, she's been incredibly important. So it's not necessarily something that you can just do overnight, but the importance of that can't be underestimated, because as you said, it's multifaceted. In Australia, and just touching on disability, we do have now the NDIS, which is a universal disability support scheme. It's been the biggest, I guess, social reform in Australia in the last 5 years. But huge issues for people with rare diseases, again, because they're not recognised, people don't know who they are, what their diseases are, whereas autism, 30% of participants really well supported, but if you've got a rare disease, really difficult to get those supports and to have them recognised. So even in universal systems, unless the structures are set up to identify people, who are only a small in number, but there are a lot of them, and the system needs to be designed to account for that. If you can't get that, then people will keep falling through the cracks.
I feel like what the patient advocacy has done has been wonderful, and they need to do it more to improve the awareness to the general public. And the more you have done, the better the society, because they know that everyone has a right to be living with good quality of life. And that's something that in some society hasn't been reviewed enough, and that need to be educated more to the general public. Keep doing that. Thank you.
I think I have to say that the rare disease group patients I met is the most active disease group I have ever seen compared to other disease group area that I've been working on. And it's not only the patients, the families, and also the clinicians and the healthcare professionals that are supporting them. All of them are emotionally attached to this cause. And I think this is something which should be continue, and it's just that because perhaps you are too few in numbers, that we need to at times to speak louder, and also to make sure that you present yourself as a united front, supporting each other to the same cause. And I think. I mean, the rare disease is not a single disease, it's a diverse disease of many hundreds of different diseases and variations. So this support would mean very much, not only to the patients, to the relative, to the family, but also to the government when they see that there is one single group that is actually representing everyone. So I think I really support what being done, and hopefully that they can get stronger and stronger.
Thank you so much, panelists, for your time. It is clear that each stakeholder in this whole ecosystem is not going to be able to make the changes that it needs if we don't work together. We know that patient action groups alone cannot make up the fundraising that would be needed to save our families, not only for orphan drugs, but for basically whole life support. And when we're talking about sustainable funds and sustainable trust funds, in this discussion, the panelists have also shared some of the various other forms of mechanisms to ensure sustainability. So some have spoken about ring fencing annual allocation, others have spoken about the usage of endowment funds. Of course, we also briefly discussed about tax incentives and how that also needs to be looked at. We spoke about match funding for some entities. And of course, that all important raising awareness and building confidence. So before I give this floor back to the MC, thank you so much for your time, for your candid discussion, for your honesty. Thank you so much for all your questions. I can see all the wonderful feedback that is there. And of course, it wouldn't be a Malaysian moderated session if I do not end with a pantun. So I wanted to say, berakit-rakit ke hulu, berenang-renang ke tepian, bersusah-susah dahulu, bersenang-senang kemudian, which means swim, swim to the right, swim, swim to the left. As difficult as it will seem, we have to work together, because only when we're together are we going to make a mark and inch our way. So thank you very much from all of us here, and take it away, MC. Over to you.
Thank you so much, Nadia, for the wonderful moderation today. I think I'm not going to summarize the session any further. She's done a great job. I think all in all, we recognize the complexity of the issues and the need for more honest and constructive discussions with all relevant stakeholders as we've had today. So thank you very much for joining us today, and to all the speakers for their insightful thoughts. I'm very pleased with the fruitful discussion we've had today, and we're not done. We will have another session tomorrow at the same time. We will be focusing on regional collaboration, and I really look forward to another productive discussion. Thank you, everyone. And I will like to ask all the panelists and speakers to stay briefly after. To the participants, thank you for joining us, but we will kindly ask you to take your leave, as we will need to proceed to our debriefing. Thank you so much, and I look forward to seeing you all tomorrow.